Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Hello, good morning again. And we are going to start with a very interesting and top-class session about anterior segment surgery. I want to thank my chair, who are Joaquin Fernandez, Meilin Chang, and Gonzalo Bernabeu. I want to present the speakers that will be highlighting this session, which are going to be excellent and very important topics, because this session is dealing with the fixation of lenses without capsular support, a problem that everybody can have, everybody can receive a patient like this, and we also about tricks and techniques to solve this problem. I want to thank Sumit Kermani, Sorcha Dugubail, Mayan Nadavati, and Sergio Gatabrava, because they are here to illustrate all of us with medical education and tricks and techniques. I thank you very much, and Meilin Chang is going to present the first speaker.
So the first talk is going to be Omid Karmani talking about angle-supported lens. So let's go with the talk. First talk.
Greetings. The voice you hear is AI-generated. The work presented is done man-made. My name is Omid Karmani, and I have been practicing ophthalmic surgery at a private clinic in Cologne since 1993. I would like to express my gratitude to the organizers for the opportunity to present this recent development, fully aware that many of my colleagues hold opposing views regarding the use of anterior chamber lenses. A 24-year-old woman underwent surgery for a unilateral congenital cataract at the age of 1, resulting in aphakia. She has worn an aphakic contact lens since childhood. Her visual acuity is 20/25 in the aphakic right and 20/20 in the left eye, with an endothelial cell count of 2,900 in the aphakic eye. The presence of posterior synechii between her pupil margin and the remnants of the capsular bag prevents access to the ciliary sulcus for a scleral fixated intraocular lens. There are limited options for treating aphakia. Because there are concerns regarding anterior chamber lenses, off-label alternatives, such as the retroiridial fixed Verisize lens, has become the treatment of choice for many surgeons. Additionally, several transscleral fixation methods for placing a posterior chamber lens in the sulcus have been developed. These techniques need time, skills, a set of special instruments, and as any other secondary method of IOL implantation, these methods are not free of potential complications, not only because of the high age of the patient group. Comorbidities are also common here. However, none of these options seemed suitable for my patient, being a phakic without access to the sulcus and a posterior iris that was largely grown together with the remnants of the old capsular bag. Therefore, I recommended that she return in a year while I explored potential solutions. In fact, it took some research and development effort, and after more than 2 years I could offer a treatment to my patient. Olaf Morker, CEO of the Morker Company in Germany, approved my proposal and brought the idea to life. The new anterior chamber lens, made from foldable hydrophilic acrylate, has an overall diameter of 12 to 14 millimeters, depending on the patient's white-to-white measurement, and features a 5 millimeter spherical optic. It includes 3 haptics arranged symmetrically in a Tristellian pattern, angled to allow smooth flow of aqueous humor without the need for iridectomy. The following video demonstrates the implantation of a +16D diopter Morker Type 37F anterior chamber lens with a total diameter of 13 millimeters. The width of the paralimbal incision is 2.5 millimeters, the pupil was constricted, and the anterior chamber was filled with viscoat as an OVD before the intraocular lens was implanted using a standard Monarch injector from Alcon. The spiral configuration of the haptics ensures the correct positioning of the lens in the anterior chamber. The entire procedure took no longer than a few minutes and was performed under topical anesthesia. Post-op dexagentamicin eye drops are administered for 1 week. The postoperative course was uneventful, with satisfactory refraction and visual acuity. 12 months after implantation, the anterior chamber intraocular lens is well tolerated. Following an initial slight loss of endothelial cells due to the surgery, the endothelial cell count has stabilized. I would like to share additional indications for the use of this anterior chamber lens model. For instance, there was a case involving complicated cataract surgery in an elderly patient with a generally poor health status, where the new IOL acted as a rescue lens. Fuchs ED was noted for both of the patient's eyes. However, the new lens was well tolerated for 12 months after implantation in this case as well. The documented loss of endothelial cells is primarily attributable to the complications of the cataract surgery. We are observing an increasing number of cases involving a dislocated IOL in the bag complex. It is anticipated that nearly 2% of all cases may occur after an intraocular lens has been in place for 20 years. This trend should serve as a warning, especially with the rising number of refractive lens exchanges in younger patients. However, most affected patients are older, and a well-functioning anterior chamber lens could provide a simple and quick treatment alternative with an expected wearing time that is significantly shorter compared to a posterior chamber lens in the bag. In the case presented here, the postoperative course was also satisfactory. The Morker Type 37F anterior chamber lens implant shown was successful following the explantation of the dislocated old posterior chamber lens complex and an anterior vitrectomy. As in the other cases, the indications for the new lens were probably well balanced. The patient is over 80 years old, in poor general health, and the eye is highly myopic. The surgery, performed under topical anesthesia, provides comfort to patients. The foldable, hydrophilic, acrylate anterior chamber implants are customized for size and designed to be astigmatism neutral with a 2.5 mm PLI. This atraumatic procedure does not require iridectomy. Patients recover quickly after surgery, with monitoring conducted through slit lamp examinations and endothelial cell count measurements. It is important to be cautious about using implants that are too small, as this can lead to pseudophacodenesis, which may result in poor tolerance of the anterior chamber lens. Additionally, care must be taken to avoid upside-down implantation, as this can cause pupillary blocking. We inform our patients that long-term postoperative monitoring is essential, and prompt IOL exchange may be necessary if adverse effects occur. The reversibility of this method is a significant advantage. Please note that no study results are yet available for the Morker Type 37 anterior chamber lens. The cases presented are individual treatment trials. Patients were informed about alternatives such as the rigid Kelman lens and intraocular lenses with sulcus or iris fixation, and they provide consent for implantation. The Morker anterior chamber lens is manufactured and delivered as a custom-made medical device in 4 to 6 weeks after prescription, in accordance with European MDR Article 2.3. Thank you for your interest, and if you have any questions, please feel free to contact me.
Okay. Now in Brussels, and I'd like to thank the organisers of the Alicante Refractiva Internacional Congress for inviting me to speak on my topic, which is iris-supported lenses, anterior and posterior. So I want to say, when and why do I use iris claw lenses? Well, I built up my experience with the lenses, particularly in the area of IOL exchange. A few years ago, we published our outcomes of 15 years of IOL exchanges, and out of this series of 492 explantation cases, 28% received iris claw lenses, which suggests that they can be quite helpful in tricky situations. But first, it's important to know about these lenses. They're made of a hard, rigid PMMA plastic. They have excellent biocompatibility and a long track record of safety. There are very few lenses on the market with quite as long a track record as these ones. But for new surgeons, you need to know you can't fold the original iris claw lenses, nor should you try to cut them. You'll sooner break your scissors than you'll cut the lens. And as a result, these one-piece lenses need to go through larger incisions of about 5.5 to 6, which can be a negative factor for this form of placement, and usually you need sutures. The original inventor was a doctor by the name of Jan Worst, and he designed the lenses in 1971. They're currently available from Oftech, which is a Dutch lens company, and there are phakic and aphakic versions available. It's interesting to note that the aphakic lenses are one piece, and they're very, very similar to his original design, which suggests that it was already a pretty good design in 71. And they can be so helpful in the absence of a capsular bag that many of us say the worst lens is the best lens. So the phakic version tends to reduce in popularity now due to the simplicity and elegance of ICLs, but it can be placed on the anterior iris as so. It's important to note that there is a cost to the corneal endothelial cells in doing so. But many patients are still treated with these lenses in an aphakic situation where it can be incredibly helpful. Aphakic lenses can correct for the internal lens requirement, and they are made of this one-piece singular PMMA lens, and you can enclavate it here on the front of the iris with these two enclavation zones, or, as you see on the right, behind the iris, where you'll see at the vertical part that the enclavation has happened. And rarely you can see them enclavated on both, like in this case report where the patient had one on the front and the back to correct for an anophthalmic eye. I don't recommend this. There's a lot of hardware for one iris, but it's interesting to note. But who can't have these lenses? Well, if you can get a regular lens in the bag, do so. Or if the capsular bag still allows you to have a preferred sulcus, this can be very, very helpful. Of course, patients like the one shown in the image here are not good candidates because they do not have sufficient iris tissue. But in addition to that, uveitis cases or ischemic vitreoretinopathies are also not optimal candidates because they tend to have a very abnormal iris and the support can be lacking. So when you're comparing the front to the back placement, people have their own preferences. But for anterior and posterior placement, you're going to need about the same size of a scleral tunnel. In an anterior placement, typically you don't need to perform any amount of vitrectomy, but while with posterior placement, it's advised that you perform anterior vitrectomy, but just behind the iris to ensure you do not enclavate vitreum while you're there. Anterior placement enclavation can be a little bit trickier where you need to create a wave. Posterior is a little bit easier to enclavate because you see the shape of the claw. In anterior placement, there's no moment where you have to hold the lens unsuspended, whereas in posterior placement, there is a stressful moment when you're holding the lens in the posterior segment, and you may not drop it at that moment. And previously, it was suggested that there may be slightly more endothelial loss with anterior than with posterior placement. Overall, when you compare the two, anterior and retropupillary seem to have equivalent visual outcomes. However, the retropupillary positioning may perform slightly better with more IOP reduction and lesser CME. So these are important to note. When placing your iris claw, be aware that most modern biometers contain calculations for the iris claw. But pay attention. The A constant is different for anterior or posterior placement. It is, of course, lower for the anterior and higher for the posterior placement. Remember, and this is something I advise my residents, if the A constant is similar to your normal lens, that's the posterior placement. It has to be a lot lower if you're putting it in the anterior chamber, and most formulae work for this purpose. This is an older video showing the technique of Camille Boudot. where the lens is inserted through the tunnel and rotated to its horizontal position so that you can enclavate it on the horizontal plane. It is also possible for these rotationally symmetrical lenses to be placed on the superior vertical enclavation position. But in that situation, you'll have to put your temporal incision, and that would be quite large. Here's the creation of the little wave to allow your enclavation. And you want a nice bite of that tissue. This surgery was performed by one of the greats in IOL placement of this type, which was Camille Boudot, who still practices today. So the enclavation is a very important part because that will hold the lens nice, and you want to try and enclavate towards the periphery so you don't get a cat's eye appearance. You close up with the suture, create an iridotomy, and you're done. Retropupillary placement is done in a similar way, except placing the lens behind the iris and lifting it up, and you can see notches where the enclavation is performed. But anterior fixation is not always the best. In the event, like in this patient, the enclavation is lost, the lens can fall anteriorly into the chamber, and you get chronic endothelial damage, and they may need a corneal graft. Posterior fixation has its own problems too, because if the lens loses its enclavation positioning, then it can fall downwards. So there are risks, pros and cons with every approach. So the take-home messages for the Iris Claw are, they're an excellent option with a very long, reliable safety record. They are dependable. In general, they're technically simple, and they do not tend to have major issues with tilt. And in addition, they have been shown over the long term to be very safe in children because it's quite typical to use these lenses in cases of IOL luxation, Marfan's, etc. The negative side of these lenses is that they require large incisions. They are made of a hard material. They typically require a scleral tunnel in order to mitigate the effect of the large incision. And you do need to order them in advance, so they can't be they're not always shelf ready unless you're doing a lot of these cases. So I hope I can show you that the Iris Claw lens still has a place in our armamentarium. Even though it's an older technique, it is still quite a nice way to fix aphakia if you have access to these lenses. So I'd like to conclude by saying thank you again for your attention. This is my email address, and I'm currently working in the UZ hospital in Brussels. Thank you very much.
Thank you very much, Sorcha, and it was indeed a very nice lecture. Now we have a very important topic, which are the suture lenses to the sclera by Mayank Nanavati. Mayank, you are the next speaker. Thank you.
Good afternoon, everyone. My name is Mayank Nanavati. I'm a consultant surgeon at Brighton, United Kingdom. Thank you, Jorge and team, for your very kind invitation to participate in this session of secondary lenses. And my talk is on sutured scleral intraocular lenses. These are my unrelated financial disclosures. I'll start by showing a simple technique of suturing the intraocular lens to the sclera. This is a simple case of a congenital cataract removed many decades ago. The patient became intolerant to the contact lens and came for a scleral sutured intraocular lens implant. As you can see, the patient also had a sector iridectomy performed. The main step here is to perform a flap or a Hoffman's pocket of some kind. There are several techniques described in the literature which you can employ here. I'm making simple scleral flaps. Then you have to make sure that the anterior chamber is clear of the vitreous. So you have to do a thorough vitrectomy, as I'll be showing here with the guide of intracameral triamcinolone. And once that is done, you can use a 9-oproline suture or Gore-Tex suture nowadays. This video is about 7-8 years old, so I'm showing you use of a long bent double-ended 9-oproline suture. This suture can be railrodded through the other side by use of 26 gauge bent needle. So you pass the needle through the 26 gauge needle and then pull the suture out on the other side. This way you've got a thread hanging in the middle of the anterior chamber, just behind the iris or pupil, and the suture can then be pulled out through the main incision to tie to the haptics. So once the needle is removed from the other side, you can then open the the main incision. Now, mind you, these sutured scleral lenses are PMMA lenses, and therefore they require big incisions here, approximately 5.5 millimeter incisions. And then once the incision is made, you then open up the anterior chamber and gently pull the suture which is hanging in the iris plane outside the eye, like so. The loop comes outside. You then cut the loop to create two ends and tie each end to the eyelet on the haptic of these PMMA scleral suture lenses. As you can see here, the two eyelets on the haptics and the ends of the prolate suture can be tied to that. Now, again, as I said, if you search on the Medline or PubMed, you'll find several techniques to do this same step. And once you've tied this is the simplest technique, which is very simple for anyone to do. And once you've tied these, all you have to do is to pull the two ends of the sutures on the side from the scleral flaps to just slide the lens inside the eye. So here I'm just tidying up the knots on the eyelets, making sure that they're well secure. It's very important to ensure that multiple knots are tied in there. And then, as you see here, I'm pulling out one end of the suture on the right hand side and pushing the lens inside. So the lens is inside, and once I pull the suture and the lens gently slides in place, then you feed the haptic behind the iris and then pull the other side equally, so the lens gets centered well. So now you pull the other side like so, just to center the lens, and you will see the lens gently move into place like so. Now, the patient had a sector iridectomy, so obviously the pupil is wide superiorly, and therefore that may create some glare issues, but hopefully that should not affect the outcomes, as the patient has lived with that sector iridectomy and contact lens for many decades. You gently close the flaps of your sclera as shown here, stitch the main wound, and finish the case as normal. So I'm just going to fast forward this to show you the last steps and tidy up the case, and this is the end. This is after the use of myocol inside the anterior chamber. Example where you can see the patient had an injury after routine cataract surgery a couple of decades ago. This was a blunt trauma which led to a subluxation of the intraocular lens in the capsular bag. I think there was some zonal dialysis in this case superiorly. However, the capsular bag seemed to be intact inferiorly and intratemporally and nasally, so there was enough support inferiorly. So in these cases, you can fixate the lens on the side where it's loosened up. You can create the flap of your choice, as I said, on the sclera or the pocket of your choice, and then pass the suture, which can be a Prolene or a Gore-Tex nowadays, one above the haptic and one below the haptic, and you can pull the haptic in place. So here, just going to fast forward. I'm going to pass the suture. This is coming from the opposite side of this, the weakness of the zonules. The 26 gauge needle goes one above and the other throw underneath the haptic, which is loose and subluxated, and then you pull the Prolene on the other side, like shown here. And you repeat that one above and below, as I said, like so, and then you pull the suture in place, and you find that the lens is now pulled upwards. Obviously, this patient had some anterior capsule phimosis, which needed YAG laser capsulotomy after 3 months of this procedure, but this patient did well, and the vision returned to what it was with some residual astigmatism because of slight tilt. Tilt can be an issue with these kind of suturing techniques. Now, this is another case where I will show you the complication of thick bore Gore-Tex suture. Here we are using a single piece CT Lucia lens to scleral fixate. You can use lenses with eyelets in it. This one has got a small eyelet near the haptics, which you can use to tie the sutures to. So we use a Gore-Tex suture in this case. So the Gore-Tex suture is passed, A2 Gore-Tex is passed through the eyelets of the haptic outside the eye, and then the suture is, the other end of the suture is then pulled through each of the sclerostomy sites under the flap. This way, the idea is to pull the suture in such a way that the lens is then slided inside the eye. However, if the sclerostomy is too big and too large, then the suture knots can slide through, and so you ensure that the sclerostomy is appropriately sized. So for here, the lens is placed inside the eye now, and the suture, as you see here, is being pulled through on one side. The lens is now centered nicely, and then knots are tied on one side. But as you can see, the sclerostomy site is so big that the knot, even after double and triple tying, is going to be too small for the sclerostomy, and that therefore it can slide through inside the eye. If this happens with the sclerostomy site, you can always create another sclerostomy, or you can use an ab interno technique to pass the suture through, which I'll show you here. So it was noted here that the knot was so loose that it was being pulled inside on the right side, as you can see here. So you can use intraoperative intraocular micro forceps to pass another suture through the eyelid, like I'll show you here. This is the suture threaded through, and you can use a intraocular micro forceps or the VR forceps to thread the suture through the eyelid, and then pull it out of the sclerostomy site, which was a fresh sclerostomy site created just behind the original one, and tie the lens back in place. And once the lens is tied up, you can then trim the knots and bury the sutures into the flap and close the flap like so. And this is the end of the procedure. So there are several techniques, as I showed you. I just showed you the basic principles of that, but if you look into the literature, there are several iterations and versions of these techniques. Generally, the outcomes of the visual acuity are similar to the traditional intraocular lens placement techniques. The stability and the positioning can be an issue because of tilt and decentration, and that depends on the suturing technique, so you have to take care of that. Post-operative recovery can be similar to the conventional lens as long as there's no complications. Long-term outcomes depends on the monitoring, because these patients can develop retinal tears, holes and detachment, and macular edema, so they do need slightly longer follow-up than the conventional patients. And as long as the visual outcomes are good, the patient satisfaction is similar to the conventional intraocular lenses. Now, just to briefly talk about the commonest complication, which is cystoid macular edema and retinal detachment with these scleral lenses. There's a very nice review published last year in Journal of Clinical Medicine by Raimondi and team, and you can see here the comparison between the different techniques they've used. The technique shows comparison of the scleral suture technique with iris clip, Calavale, angle-supported iris suture, and scleral fixated lenses, and you can see that generally the range of CME in these cases vary from 6.3 or 5.7 to 10.4 percentage of the cases. The rates are up to, you can say, grossly up to 10% in terms of CME. What about the vitreous hemorrhage? The vitreous hemorrhage can be up to nearly about 8 to 9% as shown here. And what about the retinal detachment? And as you can see here, the retinal detachment can also be similar in the range of 8% in these cases. And you can see the comparative dynamics of different techniques in this table as well. Thank you so much for your kind attention. Thank you, Jorge and team, for your kind invitation once again.
Thank you very much, Mayan. Excellent talk. And now Mei Ling Chang is going to present the next speaker. Mei Ling.
Our last speaker of this session is Dr. Sergio Canabrava from Brazil, talking about intrascleral fixation techniques. So.
Olá, um gusto estar aqui participando de ARI 2024, Joaquín. Gracias por la invitación. Jorge, un gusto estar en tu congreso que es siempre muy bien conocido. Vamos a ahora hablar un poquito del problema flanger, de la técnica en update de que tenemos desde el último año. Aquí es mi disclosure sobre la técnica, sobre que vamos a hablar hoy. Muchos no lo saben, pero la primera vez que lo publiqué, la técnica de flanger en prolene fue en un simple áptico de prolene, no fue el prolene de ahora. No se hablaba de prolene, que tuve la idea tirando de la técnica de Yamane. Después, y aquí la publicación, 2017, recibimos premios en Film Festival de ASRS, y aquí fue cuando yo cambié la idea. Mira, aquí ainda con áptico, es un paciente con white diameter muy largo y no fue posible. Entonces, después de esto, aquí es una parte de un vídeo que enviamos también para el Film Festival, tuvimos la idea de hacer un prolene enlargado, aumento del prolene, porque pensamos, mira, este áptico de prolene, ¿por qué no hacer el teste con prolene? Y aquí fue el primer teste que hicimos, 2018. Hasta ese punto, ninguna persona en el mundo de oftalmología hablaba de prolene con flanger. Entonces teníamos un poco de miedo, no sabíamos qué iría pasar, porque la técnica de Yamane era una técnica hecha con ápticos de PDVF. Entonces aquí, otros testes para saber la resistencia, se quebraba, se rompía. Mira, hoy sabemos que el flanger de prolene es muy estable, pero tienes que imaginar 2018. No había ningún estudio sobre esto. Entonces, en 2018 publicamos por la primera vez en ASRS el uso de prolene para un simple CTS. Fue la primera vez. Y después de esto, entre 2018 para frente, se desarrollamos muchas técnicas con lentes no pegables, con lentes pegables, y otros doctores utilizan mi técnica de prolene con flanger para hacer nuevas y nuevas técnicas. Esto para mí es un gusto siempre poder colaborar con los colegas. Entonces, lo que es nuevo desde 2023, que vamos a hablar aquí hoy, los 5 años que hicimos el seguimiento entre 2017 y el final de 2022, que publicamos en 2023. Después, la clasificación del flanger de la esclera y las complicaciones, y la modificación en la técnica de forflanger. Entonces, son los 3 temas de la charla de hoy. Entonces, lo que es nuevo desde 2023, entonces este paper, que es un paper free, que está en JCRS, con los 5 años entre 2027 y el final de 2022, con una media de evaluación de 28 meses, de 71 ojos, 61 pacientes, 173 flangers. Y lo primero punto, estas no son fotos nuestras, son fotos que encuentro muchas veces en la internet, que no podemos tener el flanger fuera del túnel, mucho menos fuera de la conjuntiva. Va a tener problema. Este es un punto importante en la técnica que se va a utilizar la técnica de Canabrava para cualquier una de las fixaciones, sea de iris, de lente pegable, de no pegable, no se puede. Mira, otro punto importante, revisando mis vídeos, los casos que tuve complicaciones de internacionalización de flanger, fue cuando también fuimos directo, como en la letra A, sin hacer el túnel. Entonces tiene que hacer un túnel escleral largo, longo. Aquí, los casos. Entonces, de 173 flangers evaluados, tuvimos complicaciones 9. 5 que fueron expuestos, porque el flanger estaba muy largo, fuera del túnel. 4 que se fueron directo para dentro del ojo. Fueron flangers que yo fui directo, sin hacer un túnel escleral. Y un que fue una erosión de conjuntiva con inflamación, porque también el flanger estaba muy largo y fuera del túnel. Entonces, los otros que hicimos la técnica buena, todo estaba perfecto. La clasificación de esclera, que también presentamos en ese paper. Entonces, la primera, flanger intraescleral, como podemos mirar aquí, en ese flanger, en la OCT, en la parte inferior, y se puede mirar el flanger dentro de la esclera. No hay problema, no tuvimos ningún problema. Aquí el flanger en la superficie, también no tuvimos ningún problema. Pero los casos en que el flanger estaba fuera de la esclera, como estos dos, por ejemplo, fue cuando tuvimos problema. Pero un punto, no tuvimos problema en todos, pero todos que tuvimos problema fue cuando el flanger estaba como este caso. Perfecto? Y entonces recomiendo siempre que se vuelva para el quirófano. Aquí ahora vamos a discutir los 5 principales principios de la técnica que se debe utilizar en cualquier una que se va a utilizar. Se va a fixar un CTS, una iris artificial, una lente pegable, una lente no pegable, un SESIÓN de ring, tiene que utilizar estos principios. Marcar 2 milímetros del limbo, hacer un túnel escleral largo, longo, segurar la base del problema cuando fue a hacer los últimos puntos para tener tensión. Si el flanger está muy longo, se sepulta el flanger así muy longo, que va a tener tilt, porque no va a tener tensión. El tamaño del flanger es sepultar el flanger. Entonces, este es un marcador que utilizamos. Si no tiene marcador, es importante que se va para la lámpara de hendedura para que se marque 2 milímetros de limbo. Aquí, para hacer una fixación, por ejemplo, de lente plegable de 4 loops, la distancia 2 milímetros y 3.5 de cada punto de entrada. Aquí, mira, el túnel escleral perfecto. Mira que voy paralelo con el limbo y voy a girar mis manos para entrar dentro del ojo y después voy a poner el prolene dentro del lumen y recomiendo, teste el tamaño del prolene en la aguja fuera del ojo antes. Y mira, cuando voy a ver y hacer el movimiento reverso. Y mira cómo el prolene se sale paralelo con el limbo. ¿Perfecto? Aquí, el número 3. Aquí es una foto de una lente no pegable. Entonces, mira, tiene que tirar el prolene y segurar la base. Hold the bases. ¿Por qué? Con una simple 23 gauge microforceps. Porque tiene que tener tensión. Si no crea tensión y hace un prolene muy largo, va a tener un tilt el intraoperatorio. Aquí el tamaño que se corta el prolene de 1.2 para 1.5 no necesita más que eso para hacer un tamaño de flange perfecto. Aquí, mira, por exemplo, aqui um corte de mais ou menos 1 milímetro. Esse é possível ser um flange bueno? Mira, um tamanho de flange que está bueno, ¿por quê? Porque eu hice um túnel esclenal largo, longo, não largo, longo. Como eu hice um túnel esclenal longo, não vai passar nada, vai estar perfeito ali. Perfeito, aqui, uma foto à direita, a foto à esquerda minha, um tamanho bueno de flange quando tem um túnel esclenal largo, longo, e aqui à direita, um tamanho de flange muito grande, que está fora da conjuntiva. Isso eu vejo muitas vezes na internet. Entonces, neste outro ponto, podemos mirar uma foto que também publicamos no JCRS, que foi de um flanger muito grande, que tivemos uma inflamação e uma erosão de conjuntiva, e que eu tratei com 5 dias de corticoide, 7 dias, perdão, de corticoide de moxifloxacin, e depois volvi para o quirófano para reduzir o tamanho del flanger e sepultar em túnel escleral. Aqui, podemos ver, esse é perfeito. Eu sei que nem todas as vezes vamos a lograr ter um flanger com esse tamanho perfeito, e mira, como lo consigo sepultar dentro do túnel. El perfecto, pero no siempre lo vamos a tener. Y algunas veces tenemos que volver al quirófano. Y aquí, para terminar, la modificación que hicimos, que Victoria de Rojas también, al mismo tiempo, y Ori Mahle también de Israel, que vamos a publicar en JCRS, que fue la modificación de la flange con 4 loops. Hicimos juntos, y Victoria, yo sé que está entre los panelistas de ahí. La original, con los 4 closed loops, pasamos el prolene fuera del ojo. Y después, con la modificación, terminamos siempre igual, pero ahora inserimos la lente directo en la cámara anterior. Con eso, una incisión más corta, una incisión de 2.4 milímetros, porque la original tenía 3.4, y así utilizamos la aguja para evitar que la lente se vá para el segmento posterior. Y aquí ponemos la aguja dentro del loop inferior de la izquierda, y después vamos a poner el prolene de 6 ceros, como en lo publicado en el original. Y sacamos el prolene de 6 ceros y después, más una vez, nos vamos aquí para hacer la otra pasada del primer loop del prolene que va en el lado izquierdo. Y mira, el movimiento de retirada del prolene tiene que ser paralelo. Y aquí, lo otro lado, vamos a hacer el segundo loop de la técnica dentro del closed loop de la lente. Mira, los inferiores primero, ponemos el prolene, sacamos el prolene, después de sacarnos el prolene, vamos para el otro punto, lembrando, 2 milímetros del limbo y 3.5 de distancia de cada uno de los puntos de entrada. Entonces, 2 de limbo, 3.5 de cada punto de entrada. Y aquí estamos para sacar la retirada del último loop que nos queda. Y con eso, después de retirarmos el último loop que nos queda, vamos a poner la lente para debajo de la iris, para entonces empezar a hacer el flanger número 1, número 2, número 3 y número 4. Es siempre en esta secuencia. El primero inferior de la izquierda, aquí no necesita tensión porque como es un loop, puedes manejar y este manejo del loop para dentro y para fuera del loop te ayuda a centrar la lente. Mira, yo puedo mexer en loop muy simples, muy más simple que Vortex, no es posible hacer eso con Vortex. Y después vamos a hacer al inferior de la derecha. Mira, hacemos el flanger, no necesita un flanger muy largo. Y ahí sí, nos vamos y ponemos el flanger. Y ahora también podemos manejar la centralización de la lente. Por último, ese no necesita de mucha tensión, porque vamos a hacer la regulación de la tensión y tirar en el último. En el último es importante que tenga la tensión. Mira, aquí ponemos el flanger, ya no está dentro del túnel escleral porque estamos terminando. Al final vamos a poner todo el túnel. Y mira, por último, ese ahí tenemos que tirar, porque la lente va un poquito a la derecha para después volver para la posición de centralización. Hacemos el flanger. E aí, uma das vantagens da técnica é que, além de por ter 4 pontos, não tem tilt, solo claro, se el sueño se va para adentro. Entonces, Jorge, Joaquín, gracias por la invitación. Siempre un gusto estar hablando con vosotros. Gracias, amigos.
Muchas gracias, Sergio. Estupenda presentación. Creo que está Joaquín Fernández ahora conectado. ¿Estás ahí, Joaquín? Perfecto. Hola, muy buenos días. Y gracias por conectarte en momentos que no son fáciles. Te acompañamos todos en tu momento tan especial. Gracias. Pues si te parece, te cedo la palabra para la coordinación. Tenemos a Meilín y a Gonzalo con nosotros y un magnífico panel de speakers. Podemos hacerlo en inglés, dado que hay una mayoría de speakers que hablan esa lengua. So we shall follow in English now, and thank you, and Joaquín Fernández is going to conduct the debate. Thank you.
Thank you very much, Jorge. First of all, I would like to share with you a reflection. No, it's the situation that we have with the scientific article about surgeries. I really think that we have an underreporting in literature about the scientific article about that, and probably we would need also to know more and more long-term outcomes in this technique, and also in what point the surgeon need to be positioned when they present their data, what number of cases they develop in the Leiden group. For me, absolutely amazing, all the videos. Thank you very much for your presentation. The first question would be for Sorja. Sorja, amazing your presentation. Thank you very much. It's always a pleasure. I always learning with your presentation. It's about when you implant the posterior artisan. Do you put the lens upside down when you implant posterior or not? What is your opinion about this?
For me, I think that that's a very interesting question. I started putting the lens anteriorly, so I was always, usually I use them in aphakic cases, because for pseudophakic correction, for phakic correction, we have much better options. So for me, the iris claw lenses are primarily for aphakic correction. I used to put them always on the front, but actually I started to train to rotate them underwise. I rotate them upside down, and this is important because they have a concavity to them. So if you don't put them upside down, you are more likely to completely occlude your pupil opening, and that can give some issues. Of course, I know that other colleagues, when they put posterior placement, they have nice room and flow for the aqueous to get to the anterior chamber, and they often don't even require an iridotomy. I have a preference to put an iridotomy in most of these cases. I don't think we do much harm, but actually, as long as you ensure that you've rotated the lens upside down and you can see it very clearly, it's actually very easy when you put the lens on its side to see its concavity, and that way I work with it. I think the nice thing about it is that it's very reliable. It's not that difficult for an anterior segment surgeon to work with, and it's got good follow-up data. The difficulty with it is that it's bulky, it's a hard lens, and you need to do a large suture, and we want to do fewer and fewer of these.
Excellent. I also appreciate your opinion about modify in account of the A constant in both situations. I really think if we are looking for a sensei, it's very necessary. Well, we have here two sides, no? The people implanting in anterior chamber, the people in posterior chamber. We have an incredible surgeon, Dr. Gesa. You used to implant in posterior chamber fixation. What is your opinion, Amaya, about what would be your tricks? Sergio Canabrava told us some tricks about taste at the beginning, the possibility of the size before the surgery, and taking very very careful in not have extrusion of the suture. What is your tricks about this procedure, Victoria, Maria, and Mayank?
Hello, and thank you. And I always do a flap, an scleral flap, and I think it's important because the extrusion is like an ulcer because of the touch of the prolane with the conjunctiva. So for me, in every surgery, I always do a scleral flap, and over that the conjunctiva and tenon.
I agree with you because the flaps are very important to prevent endophthalmitis as well.
And there's so many techniques shown nowadays in congresses where people are just actually puncturing the sclera, pulling out the prolene and burning it with so many lenses. I've seen some videos with trifocal lenses being implanted in that way as well. But I think the main risk there would be endophthalmitis, in my opinion, so flaps of some sort, or pockets, like Hoffner pocket, for example, would also be a good idea.
Victoria?
Sorry, I was yes. I have been performing flaps and then for a long time Hoffman pockets it was a lovely technique for me. It's very elegant, but I stopped doing that because of I had some breakage of tenor nylon sutures. It's widely described in the literature. So I started to use the technique described by Sergio Canabrava, and for repositioning lenses, the technique described by AREA, which is a variant of the same. It is really the flanges allow us to use them for a great variety of surgeries, for fixating, also iris prosthesis and so on. I acknowledge I do think it is very, very important to vary the flanges, of course, but I don't use flaps, and I have also talked with Sergio Canabrava about the point of doing or not doing the tunnel. Me and my colleagues from Coruña, we don't perform the tunnel to do the Canabrava technique. We move the conjunctiva and enter dilated where we want to enter. There is a Brazilian surgeon, I think is Mascarenhas, who also performed the same, entering directly without the tunnel. Well, I was looking for the thickness of the sclera at 2 millimeters for the limbus, which is published, and it is almost around 55 microns there. And we have performed a study measuring the size, not only the diameter, but the size of the flange, which is around 100. So if you enter dilate in a normal sclera, I am not speaking about Marfan, which I have an internalization, so does Sergio published, of course, myopic people, but in a normal sclera, you have, if you enter dilate and you vary the flange, which is 100, you have a tunnel, a vertical tunnel, but you have a tunnel of around 400 microns underneath the flange. So the proof of concept of this that I was speaking is that my colleagues and I have performed so now 100 cases of Canabrava implants for aphakia, the retina colleagues and me, myself, and also we have performed 74 cases of fixation of 22 med segments and 52, I think, repositioning surgeries. So we have a lot of plans. In total, 174 patients with these techniques, with aphakia and repositioning. And we have 3 flange internalizations, 3 internalizations, and one case I had to took the patient to the surgery again for a very superficial flange that I had to vary again. But the technique works like this well. But I think it is very, very, very important to vary the flange. It must be varied into the sclera.
Excellent, very well. Well, we have this month in the journal Cataract Refractive Surgery published a heard of print scientific article. It's a meta-analysis analyzing the postoperative complication rate in intraocular fixation method, and it's absolutely interesting because this paper, this question would be for Omid and all of you. The conclusion is overall the anterior chamber intraocular lens had higher rates of corneal edema, like Sorja tell us, and patients with scleral intraocular lens fixation demonstrate high risk of decentration and dislocation and also vitreal hemorrhages. Okay, so the author tell us that we need to take care with proliferative diabetic retinopathy with anticoagulation, and it's very interesting for me. This would be the question. Okay. The outcomes show that we could have higher risk of macular edema, and probably the author suggests probably to take more intensive postoperative anti-inflammatory medication, and probably the possibility of having subconjunctival injection with triamcinolone. What is your managing the postoperative all these techniques? Do you vary with your cataract surgery? Or what is the manner and the way that you manage, Omid, and all of you?
Well, first of all, as a cataract and refractive surgeon, I feel reluctant to do scleral fixation because I think, in my opinion, it is a very traumatic surgery. It's time-consuming, and you need a special set of instruments to do it. At the same time that I do a scleral fixation, I can do 4 or 5 normal cataract procedures. So it's also a question of time, cost, efficiency, and risk-benefit ratio. And I believe that we are facing an anachronism today. I mean, it is year 2024, and we don't have a proper anterior chamber lens to solve this problem. We do off-label procedures such as Sorcha presented. It's actually the method that I prefer also as a refractive surgeon to fixate the lens on the iris. But still I feel it's an anachronism, and that was my intention to find a modern and good solution to the problem that is simple, fast, and safe and reversible. So, of course, right now I think it's a very early stage for the anterior chamber that I presented, and certainly it is not represented in the study that you just mentioned in the ACS journal because it's very new. But if there's a little chance, let's say 1 in a 10 or 2 in a 10, that the lens, that design that I've proposed, that it works, then it's a very proper, nice solution to a problem that is increasingly taking our focus, taking our time, because these patients are becoming more and more. So usually in the cases where you do opening of the eye over 5 or 6 millimeter, I mean, of course, you have to give eye drops and all kinds of post-operative inflammation controlling methods in order to keep the eye calm. And it's a large opening. It's astigmatism that you induce, retinal detachment that you can induce. You can have vitreal bleeding, retinal detachment, all these kinds of things. And the alternative with the anterior chamber lens, of course, it's the endothelium, yes, but it's easy to monitor. And it's reversible. If you see after a couple of years that the endothelium does react, well, take it out and you can still do a scleral fixation or iris fixation. So my intention was to find a contemporary solution that is quick, easy, safe.
Okay. Well, last, Sorcha, do you want to talk about something? Yes.
I just wanted to come to the post-operative management of patients when you're using an iris fixation technique. There's 3 things that I like to think about. The first one is we're using the iris as a support tissue, and that is inherently vascularized and inflammatory. So these patients I anyway put on a higher dose of a higher dose of corticosteroids. Their wounds are larger, but I still do the same antibiotic protocol, and they don't have a barrier between anterior and posterior. So all of the cytokines and manipulation you're doing has direct access to the retina, so they do have a higher macular edema risk. So from that purpose, I do give them a longer tapering dose of corticosteroids. Regarding the endothelium, I find it really important in these patients, regardless of how you suspend the lens in the anterior chamber, whether you put it on the iris or as an AC IOL. Never rub the eye, because even though the cell loss is partially due to the flow of nutrients through the anterior chamber, you can invert the cornea with rubbing. And you can imagine if it's directly hitting against the lens, cells are being lost. And I have been surprised how that simple piece of advice can arrest a decline. So that's just, if there's any plastic in the anterior chamber, do not rub the eye.
Excellent, very well. Well, we have 5 minutes left. I would like to talk very fast about the learning curve. Okay, to all these young doctors that are listening to us, what do you think is the learning curve in each of your case for dummies to manipulate adequately, to manage adequately the procedure to all these people that young people that we are listening, they are listening to us. What is more or less the number of surgery you need to manage adequately each technique, and if in this posterior chamber need to have competence about posterior surgery, vitrectomy or not.
I can comment on that. I'm an anterior and mid-segment surgeon. I call myself a mid-segment surgeon because I do all these lenses. I don't think you need to have a VR competency for that, but you do need to have a friend who's doing VR surgery, and you should be very friendly with them, and they should be on your table as well to handle these cases if things go wrong. With regards to learning curve, I think this is not a simple case of watching a YouTube surgery or going to ESCRS, watching a video and doing your own surgery. I think this does need some mentorship, and this does need some hand-holding as well. So if you haven't done any procedures, I would suggest the young ones to ring your best friend who has done it, or actually go and visit them, do one and see one, and then do it yourself.
For the IRIS techniques, it's very straightforward to simulate it in the lab. I think the biggest technique issue with the young surgeons is dealing with a big incision and suturing big incisions. That's usually the learning curve. And many of us were used to tunneling before, didn't have that problem.
But one thing which I would mention here is most of these eyes are faking. So as soon as you put a big incision on there, the eyeball crumples. And then to put stitches on it after you put lens in, clipped lens or sutured lens, it is not easy. If you haven't done a penetrating keratoplasty or DALT before, you haven't got an experience of that, then what I would suggest is mark your cornea before you put the incision on, because the wounds are going to be distorted. The eye is going to collapse.
The lens that I was allowed to present, which is easy, straightforward, the procedure takes about 5 minutes in total, can be performed in topical anesthesia. And there's not much of a learning curve, actually. There are two things you really have to take care about. Is one, that the IOL doesn't flip around because it's bent anteriorly, so the aqueous can flow. If you put it upside down inside the eye, then you block the pupil, and then the facility of the aqueous humor is blocked. This is very dangerous. We have seen this with the cachet lens, also a foldable but phakic IOL. And the second is the sizing. We have started with a 12.5 millimeter sizing and found that it was too small for some eyes. And then we individualized it. So we measure the wide-to-wide measurement, and then we add a millimeter in the total diameter to the wide-to-wide, and we order the lens. So it's up to 14 millimeter. And if the lens is too small, then you have pseudophacodonosis. The lens starts to shake with the eye movements, and then you have to take it out, because shaking lens in the anterior chamber is very bad. So these are the greatest things you have to take care of, but that's easy to monitor.
I would highlight three points. The mentoring, I think the first cases should be performed with some colleagues which is experienced with the technique. And second, to have in mind, like Sergio has shown in your mind, a slide with the tricks of the technique, the very, very important steps and tricks for the technique. For example, the size of the length of the problem you have to hit to obtain a given diameter of the flanks, the marks, how do you perform the marks, and they, I think, they must have some knowledge about anterior vitreous management. because this is not just the experience to put a given implant in an aphakic eye. This eye, most of them are complex eye. Most of them have decreased endothelial cell count. They can have comorbidities like glaucoma. Some of them have already performed glaucoma surgery, so you cannot make fixations at 12 o'clock, and you have to perform in another places. So they have to have some experiencing with the evaluation of the comorbidities you have in mind. And also, I have to say that I forgot to saying this before, that we are doing Canabrava technique for most cases, except those cases in which we have to open a wide incision. For example, if we have to perform an intracapsular surgery, that we have to do it from time to time, or if I have to remove a PMMA lens, that I have to open a big incision to remove it from the eye, then I implant a retropupillar artisan lens, iris fixated lens. It is a wonderful option. It is very straightforward with a short learning curve. It's a very nice implant for these cases in which you have to open a wide incision necessarily.
Thank you very much. Well, thank you all of you. It was an amazing symposium. I have learned a lot. Jorge, it was a pleasure. Thank you very much for having me the opportunity to talk with my old friend. Let's continue. Congratulations for the symposium, Jorge. Nice to see you.
Thank you. Thank you, everyone.
Thank you very much. I think that we have learned a lot. And indeed, we are going to have, in my opinion, a long time to decide which is the best technique that finally will be in our hands, the one that we dominate more. Thank you very much. We close the session. Thank you, Joaquin, to be here in this special moment for you. Thank you very much.